probably on low power, the two more like visible are the superficial perivascular infiltrate that from this power looks pretty much lymphocytic. There's somewhat like what appears to be like a vesicle in the like intraepidermal vesicle
Yeah.
or two. Yeah.
Vesicle. There's a
Hmm.
spongiatic area right there. And
Yeah. There's some edema in the upper dermis maybe.
good. Excellent. It sure is. And notice it's kind of got a wedge-shaped
Yeah.
morphology to the infiltrate a little bit, and it's perivascular
Hmm.
and it's interstitial.
Yeah. And then on higher power there are a lot of EOS
Yes, a lot of eosinophils.
that at least on lower power I cannot recognize.
But at this power, you can see that they're
Yeah.
really good.
Mhm.
So what was your differential diagnosis?
So the differential when I saw this was okay. This is back bite, and then I said, "Oh, this is too easy." So there's a trick here. So then I said, "Well, maybe it's allergic contact dermatitis," but it wasn't that diffuse. So it was kind of more localized. And then the other one that I thought was I started reading about bullous pemphigoid, and there are reports of bullous pemphigoid having all this edema, eosinophilia, and some intraepidermal blisters, which is not. I'm not saying that this is BD, but I just found those cases.
Yeah, and it's be a little unusual for pemphigoid to have this sufficiently deep infiltrate. Usually pemphigoid is, as we talked about, of course you were in Africa, so you didn't hear that last week, but it shows more of a band-like infiltrate.
Okay.
Besides the eosinophil. Yes, you can get prominent spongiosis with the bullous pemphigoid with papilloidal edema. So we show some things that are, not always just impossible to diagnose in here. So, yeah, this was an arthropodocyl reaction. So, yeah. And, just, maybe an early vesicular bug bite reaction. So it's pretty florid response. So I think we might have a clinical photo of it over here. So toggle to the PowerPoint presentation. Yeah. So this guy's got lots of, maybe even some blisters with his bug bites in this case. So what bug do you think caused this?
Fire ant.
No, probably not fire ant. Why not fire ant?
I know I have never experienced.
Oh, really? Well, you
You've
need to
never
go out
been
to
by a
go
fire
out to the
ant?
country and get
Yeah.
bitten by
Are you
one.
serious?
Before you head back to Argentina, you need to experience a fire ant bite. They're not fun. I've had them myself.
You
They're
pustules.
terrible. That's right. You get pustules.
Oh, push.
So
You
your
need to be
homework
by
assignment is
fire
go get
ant.
bitten by
Holy
it. Let's bring one up here and let it bite it. Yeah, it looks kind of like sweets. Got a lot of pollen. And which bites tend to give you like bullous bites? It might even get a little blister like the photograph here.
Mosquitoes.
Mosquito, probably the most common, yeah. Mosquitoes, people that are immunocompromised for some reason or other will often get really florid bug bites. Kids get bites that are florid a lot of times. Good. Did you run into any bites in Africa? Like
Fortunately, not that I'm aware.
Arikari, like Cassian pox, and those kind of good old things. Or
Of course, no.
malaria.
Happy I'm alive.
Rubber blindness.
Okay, what about this one?
This is another punch biopsy. This one I thought was very similar to the last one. As
Yeah,
far
in
as-
some ways it is. How does it differ though from the last
It has more spongiosis.
one?
And
Really? Or
I thought so. Oh, I thought I saw more spongiosis, but it doesn't have as much of a infiltrate.
it's got spongiosis. Now it's not. So if you were to call this acute, subacute, or chronic spongiatic dermatitis, where would you classify this?
I think because of the less infiltrate, maybe more chronic.
Well, usually chronic spongiatic dermatitis kind of gives you a lot of like identification and maybe just a slight amount of spongiosis. Here you do have some early spongiatic microvesicles, so it's probably either really, really acute, early in an evolutionary stage, or it might be subacute. Okay, the last one was really a florid. We get like a spongiatic vesicle, almost a blister that formed. So this one's the same general reaction pattern, but it's just not as florid as the last one. But it is a spongiotic dermatitis. What kind of cells are in the infiltrate?
Looks like mostly lymphocytes, but I think I saw some EOs as well.
Yeah, good. There are eosinophils also. So you got a spongiotic dermatitis. The infiltrate this time is more superficial perivascular, not superficially deep.
Yeah.
Okay. Lymphocytes and eosinophils. So what's the differential diagnosis here?
So I thought about kind of the same things, bug, just drug reaction because of the EOs, but you can contact
What are the
contact
classic
dermatitis.
What are the classic sort of 5 spongiotic dermatitis that are the primary pathologic change of spongiosis?
Spongiosis, well, contact derm, ACD.
Good. Contact.
Like arthropod,
You
assaultinia.
know, bug bites generally, they often will give you spongiosis, but it's not really considered a primary spongiotic dermatitis. It's an insect, it's an insult, and sometimes you can get urticarial lesions with bites. Tick bite reaction, you may see zero spongiosis. So you don't have to get spongiosis in a bite. But you do have to get spongiosis in the 5 classic spongiotic dermatitis.
Tinea.
No. Tinea is not really, you can get spongiosis in tinea, but it's not one of the classic spongiotic dermatitis. So what are the classic, quote, eczematous dermatoses, spongiotic dermatitis? Contact is one.
Just atopic. Eczema.
Atopic is sort of considered one, but it's not a classic one. Actually, it's really 4 primarily rather than 5. And then you can get spongiosis as a reaction pattern in lots of things, like bug bites, drug reactions, Pseudohyrosia, sebderm, psoriasis. So you can get spongiosis as a reaction pattern in about 1,000 things. But there's really 4 main spongiotic dermatitis that you should never put down in the same, on a path report, path slip, because we can't tell them apart, basically. You can sometimes, but not generally. So contact is one. Nobody knows? You're going to know here in about 2 seconds.
All right.
Contact nummular dyshydrotic dermatitis and id reaction. Those are all primary spongiotic dermatitis. You have to have spongiosis in those or you don't have the diagnosis. You have a bug bite with no spongiosis. You can have psoriasis with no spongiosis. You can have sebderm with no spongiosis. You can have atopic dermatitis with no spongiosis. But you can't have those without spongiosis unless it's a late-stage chronic form and the spongiosis has gone away. So those have to have spongiosis at some stage of their life cycle.
So you said contact nummular.
Contact nummular dyshydrotic id.
And dyshydrotic.
Okay, so this isn't dyshydrotic because it's not on volar skin, but it could be contact or nummular, or id. It could be any of those 3. Can't tell them apart. It's got EOs, so that would kind of favor contact somewhat. Okay. Bullous pemphigoid could give you this pattern. This looks better for bullous pemphigoid than the last one. So this could give you, early bullous pemphigoid can give you a band-like infiltrative lymphs and EOs like this. So that could definitely be the differential.
Like IP as well, if it was dyskeratosis.
You
Right?
did lots of dyskeratosis and spongiosis with eosinophils in the vesicular stage of that, but not in the later stages, obviously. So that's another one where you do see spongiosis. So this was allergic contact. I'll show the pictures of it. Okay, so, and this would probably be kind of like a relatively early stage. If it's stuck around longer, you might actually get large, huge blisters that can develop. You get massive spongiosis with blowout, pseudo subepidermal vesicular dermatitis. So this is allergic contact dermatitis this time. But an in reaction histologically could look the same as could nummular dermatitis. Okay. What's the diagnosis on the clinical picture right here? Poison ivy, Bruce dermatitis. And if you biopsy that really early, super early, you can get neutrophils in that. Because the urushiol actually is a neutrophil chemotactin also. So if you get it like maybe on day 1, they're actually going to be polys initially. Then after a little bit, while they go away, and then you're left with this kind of pattern. It's usually more prominent spongiosis than you see here. Okay. All right. different situation, right? What part of the body are we on?
Hair bearing now.
Hair bearing. Good. So we think about different diseases immediately when we get into the hair bearing category.
So yeah, the sponge biopsy non-aqueous skin, there's a collection of cells surrounding the hair follicle in the dermis. The stratum corneum I thought was pretty much intact, and the epidermis in general looked normal.
Okay.
And there's some superficial and deep inflammatory infiltrate, but primarily surrounding the hair follicle.
Yeah, it's really follicular. It's like sucking itself to the follicle, isn't it? It's like homing to the follicle.
Yeah, so I didn't note any destruction of the actual follicle. There's no surrounding scarring, and it was primarily lymphohistiocytic. I didn't see any EOs or any other inflammatory cells.
Really? Oh no. It's always bad when you say you didn't see something and
Okay.
the professor just goes and
That's
points it
okay.
out.
Yeah.
instantaneously.
Okay, so there are
So-
some benefits.
Okay, but what else did you see? Something else that's glaringly obvious at this power that's abnormal for this follicle. Is this normal?
No,
No, it's not. What is that?
it's a campyllysis.
Well, the cells are kind of discohesive a little bit, but what's the color there?
It's clear.
Yeah, it's clear, white. That shouldn't be.
Mm-mm.
Normal, this is kind of more normal, and now we've got something here. So what do you think of when you see kind of a clear abnormality sitting in the middle of the hair follicle like that? What causes it? There's really two things that could do it.
I think about alopecia.
Well, there could be alopecia clinically. Yeah, it's possible, probably is alopecia. There's only two follicles on the scalp. But why is it clear? What's going on here?
There's been cell death.
I'm sorry?
There's clearance because there's been destruction of the.
It could be, but what if there's something that shouldn't be here that kind of decided it wanted to kind of park itself here or get produced here?
Yeah, that's what we'll do. So things that are typically are clear are like lipids.
Yeah, does this look like lipid?
No.
No, it's not bubbly at all, right?
Mm-mm.
Is it kind of slightly grayish blue a little bit? It's not
Yeah.
purely white.
Yeah, there is
Okay. So what gives you kind of a slightly grayish blue?
mucin.
Mucin. Yeah. So what's the diagnosis?
So lupus. Lupus are.
Does lupus give you mucin inside the follicular
No.
epithelium? No, it does not. Where's the mucin in lupus?
It's in the dermis typically. Like
Yeah, it's interstitial mucin.
interstitial.
Exactly. It's sitting in this area. So this is actually epithelial mucin. Epithelial mucin with lymphocytes, with the eosinophils, with epidermotropism of these cells. So what's the diagnosis?
Lichen planopilaris.
No, that doesn't give you mucin in the follicle, though. It gives you inflammation at the junction of the infundibular area and the isthmic area with fibroplasia, and it destroys the follicle, scarring alopecia. So this one, you've got mucin sitting in the follicle, the epithelium. So what's the diagnosis?
Mucinous folliculitis. I don't know what was
How
that.
about follicular mucinosis?
Okay.
Now, where do you see follicular mucinosis? Two situations where you see, three really, the two main ones. Where you see. What if it's a widespread process, say portalinerous areas with
EMF.
mycosis fungoides can give you follicular mucinosis. And what's another one? If it's a solitary plaque on
Yeah,
a
that's
10-year-old kid
the kids.
Kids.
on the face, what's that called?
Alopecia.
Alopecia mucinosa.
And what's the third?
You tell me.
I'm trying to think.
You could
Sometimes it occurs just as a coincidental reaction pattern. Somebody that might have rosacea or
Oh,
something like
okay.
that, and you use biopsy, and guess what? There's follicular mucin there for some
Oh,
reason or another.
just-
So it's just a coincidental reaction pattern. But those are the main places where we see it. So now, if you wanted to like characterize the mucin that's sitting in the epithelium, we call it epithelial mucin versus mucin that occurs in, like in this area, that's produced by fibroblasts and then and probably some histiocytes sometimes in mast cells, but mostly fibroblasts. What's the difference between the mucin that occurs here and the mucin that occurs within an epithelium? You may not know the answer to that. But epithelial mucin tends to be more acidic. It's the same kind of mucin that occurs in the GI tract. Mucin that occurs in association with cancers and that sort of thing. This mucin is hyaluronic acid when it occurs out here. There is always some mucin sitting in your dermis, so we could do it. That's why I like a colloidal iron stain. If you stain it, you're going to see this light up. Because normally there's mucin in here. If there's abnormal mucin, you can see it with H&E. You don't need to stain, but you just like to look at it in a different color. So this is alopecia mucinosa. Now, it sometimes can be difficult to tell this from mycosis fungoides if they've got epidermotropism and features of the MF up here, and the cells are atypical. That favors the alopecia mucinosa, the follicular mucinosis associated with MF, but sometimes they can be difficult to tell. Let's take a look at the clinical.
Can tinea give you that pattern as well? I was having trouble seeing the actual
Almost
mucin
never
at low
get
power.
follicular mucin and tinea. Yeah, that'd be pretty uncommon. The one differential is follicular spongiosis. That can sometimes simulate mucin. So generally that does not give you kind of that slightly grayish
I think that's
blue
kind of what
color.
So, and then the fact that there are lots of EOs
That
around.
can be seen in both,
In
but it's
both,
more
okay.
common in this pattern than it is in
Okay.
mycosis fungoides. So it will help you if it's there, but it doesn't rule it out. Okay. This one's another easy one. Did we put in too many easy ones?
Yes, absolutely. This one is a fighter.
Okay, here we have a punch biopsy of non-aquial skin. What stands out at this power is a subepidermal bulla,
Yeah, there is a blister. Exactly. Good.
and they're pale. The cells within the blister are pale, and they're neutrophils.
Good. Polys. A lot of polys in here
Lot.
too. Right in here, right?
Mm-hmm.
Okay.
And also deep. There were quite a few polys. I saw.
Yeah, very deep. Way down in this area.
Mhm.
Okay. Anything else?
The epidermis is really pale. Like it's almost.
I think you're right. I think it's kind of becoming necrotic.
Yeah,
I agree with
becoming
you.
a
I
little
think this is necrotic over here. It's like confluent epidermal necrosis in several foci. Any other features that sort of caught your eye here?
Extravasation of red
A lot
blood
of
cells.
extravasated
Some-
red cells. Okay. Anything else?
Maybe some not thrombi in the vessels, but some, probably.
Yeah, there are thrombi in the blood vessels. There certainly are. Vessels are thrombosed. What's actually causing them to be thrombosed?
The
What's that step I'm pointing
fibrin.
to? Fibrin. Excellent. So there's fibrin thrombi of numerous blood vessels. Notice how deep they go. Way down here.
Mm-hmm.
Good. So fibrin thrombi, neutrophils, nuclear dust.
Yes.
So what's the diagnosis?
Bulla sweets.
The sweets usually give you fibrin thrombi
No.
and vasculitis.
LCV.
Yeah, leukocytoclastic vasculitis. Okay? And what type of vasculitis tends to give you a lot of polys? Which of the vasculitides? Give lots of neutrophils. That can give you pustular vasculitis, like this. Which immunoglobulin tends to be chemotactic for neutrophils more than other cells?
IgA.
Good. Yes, IgA. IgA vasculitis is associated with neutrophils more commonly than other types of vasculitis. So what's the diagnosis of IgA vasculitis most commonly? What's the name for it? Yeah, HSP. HSP. And if you get that in an adult, it's often associated with kidney disease. They can be pretty sick with it. So it's one of the few situations where it's actually helpful to do immunofluorescence. If it's IgA positive in the blood vessels, then you say, hey, this guy might have adult HSP. If it's an adult, the kid, they might have it also. What do you think the clinical was? So this probably looked like a pustule. But when you get these deep areas like this, what often is seen clinically? No, you can, but not if it's just kind of a relatively smaller blood vessel in the fat, a deep area of vasculitis. How's that manifest clinically a lot of the times?
Palpable.
Well, palpable purpura is usually small vessel capillaries, capillaritis and venulitis, that sort of thing. We get down to the arterioles and the deeper blood vessels.
So I think you can have either nodules, or if it's arterial, you can have like an scar.
Yeah, stellate, like stellate, reticulate purpura when you get deeper involvement, because you get those blood vessels above it that get abnormal, so you get like a stellate purpura when you get a deeper involvement, because becomes infarcted at some point. So you get stellate purpura, gunmetal gray kind of purpura that's developing. You start to think of deeper vasculitis, and you worry that they may be sicker, they're going to get eschars, that sort of thing. So yes. So this is IgA vasculitis. It was kind of Schindlein purpura in this case. So this is what it might have looked like. It might have, generally, this probably would have been more pustular. So if you see pustular vasculitis, think of HSP in this situation. All right, good. All right.
That was a tricky one.
Why?
The vasculitis and the bullous like together.
Well, it's just one manifestation. What are some other manifestations you can see with vasculitis?
Yeah.
So what are some of the other clinical features you can see with LCD? Here we got sort of
Just
nodular,
Purpuric, yeah.
palpable purpose, those classic. What are some others? We know pustules and blisters, you just said that. What are a couple of others?
Ulcers.
Ulcers. Good. What else? You said it earlier. Yeah, eschars. That kind of goes along with ulcers. Particular
Just urticarial plaques.
urticaria. Yeah, urticarial vasculitis. Absolutely. Petechiae. See that with vasculitis. Nodules, deep nodules. So lots of different clinical features of vasculitis. So this one just happened to have a lot of polys and neutrophils and pustules. Okay, who wants to give this one a go?
I can go with this one.
Yeah, well, you got to let your colleagues go. You've had a couple of people that haven't gone.
Go.
We have the shave biopsy,
Good.
and from low power view like this, you can see that there's a really dense
Excellent.
inflammatory infiltrate.
Yeah, dense diffuse, even though they did a horrible, ridiculous shave biopsy on this, but it's dense and diffuse. Now, to their credit, they may have done a shave because they thought it was something else. We're going to assume they really didn't think this was inflammatory and that they need to have their head examined.
And then
So what do you think they might have thought this was clinically? That it's reasonable to do a shave biopsy on it?
maybe a basal cell.
Yeah. They might have thought it was a squamous cell because it's kind of verrucous. It's got prominent epithelial hyperplasia. They might have thought it was a wart or something like that. But it has a dense diffuse infiltrate, and what kind of cells are in the infiltrate?
At least lymphocytes.
There's some polys, but notice that this isn't jet black. The cells aren't really dark. Do they look sort of like the last case?
No.
Oh. Try
I
again.
guess, yeah.
They do. A lot of them look like neutrophils at low power. And some of them are paler. So we have a suppurative granulomatous dermatitis with pseudoepitheliomatous hyperplasia that's dense and diffuse. So what things do you think about when you have that pattern at low power?
Neutrophils. Maybe like sweets.
You could think of sweets, but sweets usually doesn't give you pseudoepitheliomatous hyperplasia and also doesn't have histiocytes and granulomatous inflammation. It's mainly just kind of pure polys over a broad front with papillodermal edema.
Infectious.
Infectious diseases, yes. And which infections most commonly give you this pattern?
Bacterial infection with neutrophils.
They can, but less which kind of bacterial infections? Because you have bacteria, lots of different bacteria in the world, right? There's gram-positive, gram-negative, there's gram-negative cocci, gram-negative rods. Which bacterial infection do you think would be most likely to give you a suppurative granulomatous dermatitis with pseudoepitheliomatous hyperplasia like this?
typically, whenever I think of gram-positive, it's not like this, and that's what we're used to
So
seeing.
you're thinking like a regular pyogenic granuloma, like pyogenic infection, like staph or strep or something.
Mhm.
They can, but usually not. They usually don't give you suppurative granulomas dermatitis. You just give you suppurative, like an abscess, for example. So if you get somebody comes to the clinic with an abscess, if you biopsy that, it's just a sea of neutrophils. But if you get histiocytes with pseudoepidermolysis hyperplasia,
Then more like a fungal infection.
fungal, what kind of fungi?
Hmm.
Like tinea?
No.
Not usually, no. Which ones like to give you this pattern?
More like the deep fungal
Deep
infection.
fungal, yeah, the deep
There's
fungal infections.
Others, I don't know.
Which kind of deep fungal infection are we looking at here?
That's blast.
Yeah, blasto. This is a broad-based budding yeast. Looks beautiful for blastomycosis. See it over here? So this is blasto. So when you see this pattern, you should think about deep fungal infections. Blasto, cocci, paracocci if you're in the world of South America. What about in Africa? What do we think about over there, Dario?
You can think of so many things with, yeah, with HIV patients. You can pretty much think of everything.
Do you get North American blasto in Africa?
I don't think I have
Not
seen.
very commonly. Yeah, it'd be kind of funny. It'd be kind of an imported
Yeah.
disease. So there are
But
keloidal blastomycosis theoretically, lobo that could occur over there. So there's a number of other diseases that are not indigenous to Africa. So this is blasto. So just remember when you see this pattern, think of infection. Now the one bacterial infection that could give you this would be an atypical mycobacterial infection. Okay, so we have a picture of that.
Here come big green leafy veggies.
Is that one of your mnemonic
Mnemonic
devices?
for the pH with, yeah, it's kind of.
Good. Remember that. Boy. Okay. All right, now the next one. Okay,
So looking at a shape biopsy,
good.
and then we go down. Looks like there's a lot of inflammatory infiltrate.
Yeah, there's some type of inflammatory infiltrate. Does this look like the neutrophils we've seen in the last couple of cases?
Lymphocytes.
There's probably some lymphs down here, but do these look like exactly like lymphocytes at low power?
No, they
A little
look
different, don't they?
Mhm.
A little different. There's more cytoplasm. Well, what are these things? We're going to go to higher magnification. What do you think this thing looked like in the patient?
So, maybe look like a darker.
Well, this thing's kind of got a dome shape to it.
maybe like
Was it
a
scaly?
verrucous. No.
No. Probably a dermal-based dome-shaped papule or maybe a plaque. Okay? Because it's like a dermal infiltrate, right? An infiltrate of these cells in the dermis. And now they're definitely not lymphocytes, are they? No. So what are they?
So they look tend to look like they're just like fried, kind of look a little almost fried egg in appearance.
Yeah, they look like little fried eggs. It's time for breakfast, right? So what cells look like fried eggs in the skin?
Mast cells.
Mast cells, good, excellent. And there's also, look at all the granules in the cytoplasm.
Kind of creamy.
Yeah.
Yeah.
Now, is this a mast cell? It didn't look like a fried egg. That looks a little different, doesn't it?
Mm-hmm.
What does that one look like? It's elongated, it's elliptical. It kind of looks like a hot dog maybe, or maybe a sausage or a football.
Like just a spindle-shaped mast cell.
Well, it's the same mast cell, but it's cut in longitudinal section rather than cross section. So that's the same mast cell, it's just if you cut it cross section, it looks like a fried egg. If you cut it longitudinally, it looks a bit more like a hot dog. Now you can't get spindle morphology mast cells in this. It can't happen. It's relatively uncommon, but you can see it. So what's the diagnosis here?
Mastocytoma.
Good, mastocytoma. Excellent. So it's not urticaria pigmentosa. You know, it's a solitary nodule. Now, this is the kind of thing that the board exam might show you and expect you to get the answer really pretty quickly and then ask you some second order questions like what kind of granules are sitting inside these cells here? What kind of special stain might you do to prove that this is a mastocytoma? Of course, we would never do a special stain on this, right? You don't need to. But what granules are in here? What are some of the biochemical histamine? What else is in there? Tryptase is in there. What else is in there? There's one other one that's in here. If you've ever biopsied a patient with urticaria pigmentosa or one of these diseases, they bleed a little bit more than they should. Why is that?
The heparin.
Heparin. Good. So those are some of the things that are in the mast cell granule. So beautiful example with a clinical picture of one. We don't, but we should. Yeah, we need to get one. It's a really pretty classic. They kind of look like, we're talking about urticarial lesions. They're kind of they have podarons. They're kind of a skin-colored, either pink, orange, or brown papular plaque, often with prominent follicular osseous. Okay. All right, let's give this one a go.
Alright, so this is a punch biopsy.
Good.
And so we have something striking at the bottom, which is this large or enlarged blood vessel.
Yeah, there's a prominent blood vessel near the base of the specimen, and if you actually look up here, there's also another relatively large blood vessel in this area.
Yeah.
Okay. You notice anything else about the blood vessels?
There's an infiltrate
Yeah.
that is predominantly lymphocytic with many EOs.
Good.
And there are,
Lymphocytes, neos.
yeah, and there's like surrounding those blood vessels, there are like this myriad of tiny new blood vessels forming around.
There's a couple little small blood vessels. Yeah, I would
I
agree
saw
with that.
like all kind of surrounding the area,
What about the endothelial cells of these blood vessels?
and they are very prominent.
Good. So what's the diagnosis?
So the diagnosis would be angiolymphoid hyperplasia with eosinophilia.
Good. Excellent. That's exactly what this is. You know, you can look at these very large, prominent hobnail endothelial cells here. This is classic when you see these kind of things right here. And the blood vessels usually are pretty large. They're thick-walled, they're very large, so it's pretty characteristic of this condition.
I'm sorry, I was kind of like,
Tons of EOs.
yeah, tons of EOs, and that's muscle, right?
Yeah.
This is a deep punch.
Yeah.
And
I was like-
pretty aggressive.
Yeah, so when I saw the muscle and all these EOs surrounding that structure also, I was thinking if there was any overlap with eosinophilic fasciitis, or could there be any associate? No, I don't think, it's completely two separate entities, that's why.
Yeah,
Oh.
you need to actually, and you don't get these kind of blood vessels in eosinophilic fasciitis. That's
Okay.
basically in the family of morphia
Okay, yeah,
and sclerodermas in that category. It's a sclerosing process. You
yeah.
can't get lymphocytes and eosinophils in that condition.
alright, yeah. So basically that muscle was just like a finding unrelated.
Well, yeah, it's probably just they took a deep biopsy and they got some muscle and the infiltrate extended that deep.
Okay.
So this is angiolymphoid hyperplasia. That's what they look like clinically. So they often occur on the head and neck area. They may have just biopsied down into the deep, muscularis of the, probably not the scalp. It's probably like maybe around the ear is a common location for this too. So it's a nice example. What's the other disease that looks like angiolymphoid hyperplasia, but it's not the same entity clinically?
So it looks the same or similarly.
Histologically, it looks the same,
histologically.
but clinically, it's a different disease.
Kaposi's?
No, not Kaposi's. Occurs in Asian men.
Yeah, it's Kimura's disease.
Yeah, yes, Kimura's disease. It also shows features of angiolymphoid hyperplasia eosinophilia histologically. Sometimes you get eosinophils circulating and not that many actually in biopsy. You can still have it if they get the large blood vessels. All right. Different situation here, right? Let's give this one a go.
Alright, so we have a shade biopsy here. Just from low power, not too much of an infiltrate.
Yeah, pretty sparse.
A little
If it's
bit.
very vascular infiltrate, a little bit subtle.
And stratum corneum looks uninvolved, looks like non-volar skin.
Might be a little thick here and there.
Yeah,
Maybe they rubbed it a little bit because it might have been itchy.
Mhm.
Don't show them the picture first. You're cheating. Don't help. We don't like helpers. It's disempowering to people.
a little bit of acanthosis
Yes, good.
around there. And then, yeah, this one also saw quite a bit of pigment incontinence.
Good. Pigment incontinence in here. Anything else?
I thought also on this one, and maybe I was just making it up, but there might have been some kind of groups of kind of amorphous material.
Yeah.
Thought it maybe
Good.
this
Excellent.
was-
Where is that amorphous material located?
Yeah, right there, right near the junction
Yeah, in the papillary
between
dermis.
the.
Notice you got a little ball and claw type morphology here. So what's the diagnosis?
So amyloid.
Yeah, macular amyloidosis. It's got lichen simplex chronicus because it's itchy, right? Some thick cornified layer, looks like volar skin, but we're not on volar skin. Got a couple of melanophages in here. You'll often see some dyskeratotic keratinocytes. So good, macular or possibly lichen amyloidosis, same disease. Starts with macular, it's itchy, then it gets rubbed. Should you work this guy up for myeloma and all sorts of other gammopathies and those kind of things?
And this one, probably not.
Probably not, or are you definitely gonna go for it?
I don't think so.
No.
Not
What amyloid is-
nodular,
Yeah, where does this amyloid come from?
just from the rubbing and scratching.
It comes from the epidermis.
Yeah.
So it comes from the keratinocytes. They degenerate and form this amyloid, and I don't know why in some people it forms amyloid, some people it doesn't. This is just macular or lichen amyloidosis. Now you can show your picture if you want to. So usually it's not in a dark-skinned patient like that. It's usually somebody that's kind of got maybe type 3-4 skin, and they get just areas of dyspigmentation and lichen simplex chronic. That looks almost more like everything that's from a person. It's not the world's best example of the clinic, but anyway, that's macular or lichen amyloid. Okay, who wants to give this one a go?
So this is a shave biopsy of non-acral skin. There's some irregular acanthosis in parts, and there's also some compact stratum corneum. With generally the lesion is papillomatous.
Yeah, you think it's a neoplasm?
Yeah, correct.
Good. And you'd like benign or malignant?
I wasn't sure, but I think benign.
Good, benign. It's small. If you look at each one of these little aggregations themselves, pretty symmetrical. No striking atypicality, no mitotic figures. Good.
So within the epidermis, there's expansion of the epidermis, so acanthosis type changes. There's areas of pallor, alternating with not the areas that aren't as pale. I thought initially that maybe there were coronoid lamellae, but it's not well defined.
Yeah, I think that's not a bad observation. I think there may be some cornoid lamellation. I'm not sure you're right. I don't think it's really a classic cornoid lamella, but there's a tiny bit of cornoid lamellation going on here. I agree.
And then I thought maybe about like warty changes also.
Yeah, absolutely. It's very verrucous and papillomatous, like you said before.
So my differential was warty dyskeratoma.
Now, what do you usually see in a warty dyskeratoma? Why is it called dyskeratoma?
Yeah, you see more destruction, I suppose.
Well, what's the reaction pattern they see? Not destruction, but there's a reaction pattern.
Dyskeratosis.
Yeah, it's focal acanthlytic disc keratosis. It looks like Rover's disease, but it looks like a cyst. We don't really see that here, so we pretty much quickly reject that, right?
And then I thought about verruca vulgaris.
It does look a little warty, I agree with that. It's got a couple of other changes right here.
Okay.
What is this little thing here? What do we call this?
It's almost like a nest.
Yeah, we call it a squamous eddy.
Okay.
A little group of keratinocytes that kind of form this little whorl in here. It's not a keratin pearl, because these are cells. It's not keratin, so it's actually a little whorl within this sort of verrucous morphology here. So any idea of what the diagnosis
So
is?
it's like a seborrheic keratosis
Well, not exactly.
or a squamous cell.
It's not cancer. It's benign, right? So it's not a cancer. It looks warty.
Then actinic keratosis.
Well,
Well, sorry, that's not mine. Sorry.
We're gaining on it. Anybody have any other ideas?
So the tricholemal, like
Yeah,
tricholemomas or
like
tricholemal verruca.
Trichomal verruca or like a verruca with squamous eddies or an inverted follicular keratosis. IFK. So it's basically just a benign lesion, a wart with these squamous eddies. It's not really a classic trichomoma. This is probably a little follicular hamartome over here. So these things kind of go together. But it's a totally benign lesion, not cancer. So squamous eddies means benign. When you see this, it favors a benign process. So if you're kind of thinking, gosh, I'm worried it might be a squamous cell, notice it doesn't really have any atypicality or any mitotic feature to speak of. If you see these kind of changes, that favors benign. And you've got some other kind of warty features over here. So, we call this basically a wart with squamous eddies. Picture this, I hope. They usually are fairly non-specific. That doesn't usually look quite that prominent. Usually they're just a little smaller than pathways.
And then trichoblastoma and trichoebs are more
Those
basal.
are more of the inferior portion of the
Yeah,
follicle.
and
This
more
is more
basaloid.
the infundibular portion of the follicle. Yeah. Yeah, more basaloid. Okay.
Okay, here we have a shade biopsy, non-equal skin. What stands out is there's a little activity there at the DEJ, epidermis.
Yeah, this is hard to see much on low power, isn't it?
There's a little bit of a superficial, maybe perivascular infiltrate, but that you can kind of see. I think there's a little bit of an interface.
Yeah, so it looks kind of like inflammatory when you first start looking at it. If you look at this side, what does this look like?
Adenoid.
Well, there's some clear cells in there, but to me they look largely like they're kind of just pale keratinocytes.
Yeah, because I was looking at them closer, they didn't look like atypical lymphocytes.
Yeah, it looks pretty much kind of like a solar linigo if you look at this side. Let's take a look at this side over here, however.
So here,
And this is very subtle. So the board exam would never give you this at all. So you're never going to see this in real, on a test. You might see it in the real world, and it's probably educational for you to know that this happens sometimes, but this is not a board exam type of situation. You'll never get this on a board exam. What's going on up here?
nesting.
There's some nesting, yes.
There's
So you've got some
nesting,
nest
so-
of melanocytes, and then you look over here, there might be a sprinkling of occasional possible melanocytes here and there.
Mhm.
So this isn't a real good example of this process, but what this is a melanoma in situ that's very subtle, which got some lymphocytic infiltrate that occurred in continuity with a solar linigo.
Okay.
So it's very difficult to diagnose this here. So this isn't really fair game to give as an unknown with no history. You can't do it. It's not really diagnostic. But it's educational because it shows that sometimes you can get very subtle changes in melanoma in situ. That may be a melanocyte in mitosis, which is a clue. If you see intradermal melanocytes that are in mitosis, that favors melanoma in situ. So this is a super subtle, impossible to get diagnosis this time. But you need to know, because sometimes you'll take a biopsy, you think it's melanoma in situ because it's subtle, it doesn't fit. It would never look like that, because that's like a dangerous doctor question. If you see under the board and you don't say melanoma, you should fail. So they do have dangerous doctor questions, by the way, on the board. All right, let's move on to one that we can kind of figure out. It's another unfortunate biopsy because it's an inflammatory process that they shave, which we don't care for that. Why do we not like that, by the way?
You cannot see the extent of the inflammation.
Yeah, if you look at whether it's superficial or superficial and deep, if it's superficial and deep, it gives a whole new pattern of disease. So you say, well, I can't tell. If it's superficial and deep, I just have a superficial biopsy, so it's really substandard to do a shave of an inflammatory skin disease.
So you've already said it's a shave biopsy, and it looks like there's lymphocytes.
A lot of lymphocytes, yeah. There may be some other cells too, but if there's lots of polys here, a lot of lymphocytes, and maybe some polys up here.
And you can see some interface.
Okay, good. You do see interface. Notice that you can't draw a nice line where the epidermis ends and the inflammation begins over a large part of this stuff. So that's a true interface dermatitis. What about the cornified layer?
Maybe some para.
There's parakeratosis. There's also some pink amorphous material in there. What do you think this stuff is?
Serum crust.
Yeah, yeah. So what do you think this thing felt like clinically?
Something that was crusty.
Yeah, crusty, scaly, rough. This isn't going to feel like the mastocytoma is with a nice smooth surface. It's going to have a very crusted surface. So interface dermatitis with lymphocytes, with some polys in the cornified layer, with some dyskeratotic keratinocytes here, no eosinophils, none, zero. What are these cells?
They look like lymphocytes.
Well, there are a lot of them that are lymphocytes, but what are these right here, these red ones?
Oh, extravasated.
Extravasated red cells. So what's the diagnosis? If we had a deeper biopsy, it would probably be superficial and deep, and it would probably be somewhat wedge-shaped, with interface change, with extravasated red cells, dyskeratotic keratinocytes, and a crusted cornified layer with parakeratosis containing polys. Anybody know what the diagnosis is? Pleva. Good. Pityriasis lichenoides. This would probably be the more acute stage of it. So the left is more acute, the right's kind of more chronic. Sometimes the chronic histology is present in fairly acute lesions and vice versa. So we sort of don't like to make a decision whether it's acute or subacute based on the histology, but this would favor that it's more likely the acute form. Good, so pityriasis lichenoides. No eosinophils in pityriasis lichenoides.
Can MF give you interface and
It can, but usually not all that purulence, crust, and all that other stuff. Most of the time, that's usually not that acute. Okay, this is a good one also. Very good histologic reaction pattern here.
Looks like a punch.
Yeah.
University is non-aqueous skin. So, kind of starting from the top, see like a subcorneal.
Subcorneal pustular dermatitis. Good. Excellent. So why is it good that you're able to pick that up so quick like that? Yeah. There's not that many things that cause it. You're talking maybe 4 or 5 things. So what's your differential?
So first thing would be like a Tigo infection, bullseye Tigo.
Yeah, Bolsomatigo. Excellent. What else?
And then I know BP, I can cause it? No.
Not bullous pemphigoid, but there is another type of immunobullous disease that can give you subcorneal pustule.
Oh, Snedden-Wilkinson.
Now that's not an immunobullous disease, but yes, that's correct. What is Snedden-Wilkinson probably?
So a form of psoriasis.
Yeah, probably pustular psoriasis. Good. What other infection? Somebody's whispering in your ear. You know, that's-
Is it not tinea? No, not tinea.
yeah, tinea, fungus. Tinea, Candida can do it sometimes, pustular lesions of candidiasis. And then superficial pemphigus, and then, pustular drug reaction, AGEP, which is probably another form of psoriasis. So this is basically, in this case, it's bull's impetigo. Now, if you did a gram stain, you might see organisms here, you might not. Sometimes the bacterial infection is sort of situated away from the area, and it's the circulating epidermolytic toxin that basically causes the blister, and you can still get neutrophils there. So in this case, it was bull's impetigo. So that's good. This is a differential diagnosis of the subepidermal, subcorneal pustular disorders. And with these things, the right picture is pretty cool because when these pustules rupture and kind of go away, they lead to this collarette of epithelium like that. So that's very characteristic of spongiotic dermatitis or spongiform pustule or this kind of change. You get that collarette of epithelium. So that tells you what was there before. So the little blister burst and left you that little epithelium at the end. Okay.
So we have a shape biopsy here.
And another crappy biopsy, sadly enough, that we really needed a punch biopsy. So this one also is not a good example of what we are looking at here. So, but tell us what you see, and we'll see if we can get a diagnosis for you.
All right. So what you see from the low power is this superficial, apparently perivascular infiltrate, and it's a little bit interstitial too. It's not just like.
Yeah, it's hard to really talk about the pattern when you're shave biopsy.
Yeah.
What kind of infiltrate we got?
Yeah, it's lymphocytic predominantly.
Yeah, there may be some other cells in here also.
Like
These-
lymphohistiocytic, maybe.
What about these?
EOS, yeah.
EOS, okay.
Yeah.
And it's also involved in the interface, right?
Yeah.
There's also some dyskeratotic
Dyskeratosis,
keratinocytes.
yeah.
And then what are these cells?
And these are melanophages.
Good. So what disease do you know gives you an interface dermatitis with lymphocytes and eosinophils, dyskeratotic keratinocytes,
So
and deep melanophages that occur down in the reticular dermis, not just beneath the epidermis?
yeah, the first thing I thought was fixed drug.
Good. So this is a fixed drug reaction, fixed drug eruption. But it's usually we like to see superficial and deep infiltrate there.
Mm-hmm.
So if we just saw something like this, we might think of a non-fixed drug reaction. You might think of, again, maybe an unusual spongiotic dermatitis might be further exacerbated because it's got some dyskeratotic keratinocytes. So it'd really be nice to get a punch of something like
What
this.
about a lichenoid reaction? Because I was looking at the way the infiltrate is like extending and all this old pigment down there. So I was thinking maybe it was like some sort of also like resolving or not that acute lichenoid dermatosis.
Well, generally most of the lichenoid conditions don't give you EOs.
Okay.
And this, the fact that it's got these multiple deeper melanophages kind of means it's sort of come and gone at the same site over and over again. So that's kind of what bugs me. But that would have been nice to punch biopsy.
And EM, that one.
EM's in the category of
less
fixed drug also. It looks similar, but usually very few eosinophils in that. And not the deep melanophages because it doesn't tend to come and go at the same site. Okay, got a couple more to do here.
And another shave here. Maybe it was a little papule. Maybe it just is the way the cut came together. But a little shave. In this power, there's a little bit of an infiltrate.
Is it mostly inflammatory or neoplastic?
I think it's mostly neoplastic. I
Good.
think this,
Which differentiation?
This one melanocytic.
Good. So we have two items of differential there that we're concerned about, right? Melanoma and nevus. So which did you favor?
This one was tough. I thought that I saw the nests that are of melanocytes that are at the junction.
Good. They're mostly at the junction. Relatively little pagetoid spread.
Yeah, they aren't really moving up too much. Didn't really see.
Any mitotic figures?
Thanks.
Good. That means no.
Yeah.
What about
So, no.
breadth, symmetry, circumscription, all those kind of good things?
It looks like it's well circumscribed.
Well circumscribed,
It clearly ends
symmetrical.
on the edges.
So what's the diagnosis?
So I'd say nevus,
Nevus.
EVGN.
Dysplastic nevus, good, which we don't like that entity so much. But the one thing about this so-called dysplastic nevus is that it's got these kind of larger cells with a little bit of slight pagetoid spread. And this is what we see in a special site on the breast. So this is a so-called dysplastic nevus on a woman's breast. And these often look a little bit atypical histologically. Still benign, not severely dysplastic nevus, not possible melanoma, not we have to re-excise it, not get paranoid about it, none of that stuff. It's just a totally benign compound dysplastic nevus on somebody's breast. And that's what it might have looked like clinically. Okay, nobody thought it was melanoma? Good. You guys have nothing but pure confidence, right? Okay, last one.
Okay, punch biopsy, non-acral skin. In the dermis, superficially, there is a.
Is it only superficial?
Oh, I'm sorry. A deep. Obviously. There is a collection of dark pink cells.
Yeah, cuboidal cells.
Cuboidal.
A pinkish color in some of them. I agree with that.
Um,
Neoplasm then?
Pardon?
A neoplasm,
Yes.
correct? Yeah. What kind of differentiation?
Sweat gland, the pink.
Sweat gland. Good. Now we have two types of sweat glands in our body.
Mm-hmm.
Which one do you think this one is more likely to be?
Eccrine.
Yeah, probably
But
eccrine.
you don't
When you get the small cuboidal cells like this, it kind of looks sort of very similar to one another, monomorphous like that, that favors eccrine. Now, people argue about whether it's really eccrine or acrine, but I think it's eccrine also.
I don't see any clear cells, and it doesn't look neoplastic. I mean, not malignant.
Good. It looks benign. It's relatively vertically oriented. Individual aggregations are well circumscribed. You draw a line around it.
So
They're also pretty symmetrical.
you can,
However, there's one finding here that I just noticed that I want to point out to you what's going on right here.
so there's some bright red cells.
These cells have pygnotic nuclei and little karyorrhexis going on here. So what's happening right here?
Well, if this karyorrhexis, maybe it's a little like necrosis.
Yeah, it's like a geographic necrosis. Does that favor malignant? Should we say, oh my God, this guy's got a cancer?
No, I don't think so.
It doesn't. This breaks the rule. It does in other entities. So if you see large areas of necrosis in a neoplasm, you should think of malignancy. But in this specific situation, it's actually very common to see it. So what's the diagnosis?
Nodular hydradenitis.
Yeah, and it's actually got a poroid morphology to some of this. And in the poroid lesions, you get areas of necrosis like that. It's very common in poroma, dermal duct tumor. You don't usually get it in hydrocanthoma simplex, but you can see it in poroid hidradenitis. So it actually it doesn't mean that it's malignant. Notice there's really no atypia, there's no mitotic figures. So we have a clinical photograph. So a hidradenitis in this case, nodular hidradenitis, which got poroid features. So good.
So the difference between the dermal duct tumor and the nodular hidradenitis is the depth.
Yeah, generally, and usually dermal duct tumors have more little smaller aggregations in the dermis. Usually, kind of doesn't get down around this deep. But those are more just kind of fine-tuning points. If you got this into the category of benign adnexal neoplasm with eccrine differentiation, you're good.
Yeah, I was like dermal duct tumor, and I was like, what's
I
the difference?
thought poroma,
What's the
that's all
difference?
it
Yeah,
is.
what's the difference? Well, poroma usually
Poroma's got constituted the epidermis.
is exact,
Oh,
it's connected to the
So
epidermis.
that looks like
and also they'll have like pools of sweat, right?
no sweat in
Or
it,
not?
but you just have contiguity of the epidermis, and it's got these poroid cells. Okay, very good.
Thank you, Dr.
Thank
Thank you very much. doing better.